to the next speaker. Dr. Sheetal will be speaking a little later because she's got some problem with the laptop, but we go on to Dr. SUPRIYA SAMAK, Sri Ganesh. She's a young upcoming surgeon who's doing quite a bit of research work and clinical work, and I'm very proud to say that she's my daughter who's joined me in my practice, and she will be talking on managing post-op refractive surprises, because this is something you will have an unhappy patient. Whatever you do, about 5% of them may be off target, and these are the patients that you have to manage properly, otherwise they keep going from practice to practice, and it is difficult. If it's difficult to give them a solution, then they will keep away other patients from your practice. So managing these unhappy patients are very important, and she'll be talking about managing post-op refractive surprises.
A very good afternoon to all my colleagues, my teachers, and my friends. So thank you, Dr. Ganesh, for including me in your IC. I'm very honored to be here today. So today I'll be talking about managing post-operative refractive surprises, and for this talk I thought I would keep it interesting and video-based and case-based. So I did go into do a deep delve into the archives of the past 10 years of Dr. Ganesh, and we will be seeing some very interesting surgical videos, and yeah, so let's start. So first of all, when we have a patient with a post-operative, post-cataract refractive surprise, we always ask ourselves, why the surprise? So the first thing we do is recheck the biometry and make sure that we've used the correct IOL formula for the correct patient. This was very beautifully elaborated by Dr. Gaurav. Always correct cylinders with either toric IOLs or with LRIs, and make sure that we've operated on the right patient, on the right eye, and make sure that there's no human error in data entry. Now, in minus residual refractive errors, we have to keep in mind the adjustment for sulcus IOLs. We have to keep in mind bag distension syndrome, especially in patients with high myopia, and also capsular contraction. And for plus residual refractive errors, a couple of things is the patient may have undergone refractive surgery many years ago and not given that history, or it happens sometimes with plate haptic lenses. So this is again a chart from drhill.com, which tells us which formulae to be used for what type of eyes, which was dealt with previously. So now what are our management options? First of all, it's very important to speak to our patients and communicate with them as to why the error, what's happened, and give them the options for management. Of course, you can go ahead with non-surgical management, which would be spectacles, contact lenses. And the surgical management can either be cornea-based or lens-based. So corneal refractive surgery, we can go ahead with PRK, LASIK, or SMILE, and lens-based options are IOL rotation for toric IOLs, a piggyback IOL, piggyback ICL, IOL exchange, or a few unconventional options which we'll be talking about. So coming to cornea-based procedures, we usually go ahead with these procedures when the error is less than 2 diopters, there's no corneal pathology or dry eye, and the patient isn't really experiencing any glare halos or photic phenomenon. So how long do you wait to carry out a cornea-based procedure? In PRK, once the manifest refraction is stable, you can go ahead with it, but LASIK, it's better to wait 3 months after the initial surgery. Now, I'll be mostly elaborating on lens-based procedures, as Dr. Sri Ganesh and the other speakers have elaborated. Toric IOL rotation has to be done within 2 weeks. The eye trace is a useful tool in this. It tells you exactly how much rotation will give you how much change in the cylindrical power. So you can also do a secondary piggyback. So this the calculation is an axial length independent calculation, and it's based on careful manifest refraction basically. So the formulae for piggyback sulcus lenses are as follows. For an underpowered pseudophakic or a patient with a hyperopic refractive error, these we add +1, 1.5 or 1.4, 1.3 into the spherical equivalent, and the same thing we do for myopes, but we subtract -1. So now which lenses to use as a sulcus lens for a secondary piggyback? So you have your Rayner Sulcoflex lenses. You can use 3-piece silicon IOLs. Star or any other ICL is useful. Basically, the idea is we need to use silicone lenses, need to make sure that the size of the optic is a little larger, 3.5. And we need to make sure that it's a spherical IOL. Okay, so this is the Sulcoflex lens. This is a single piece hydrophilic acrylic IOL, 6.5 mm optic. Optic has a round edge. So basically, in square edge optics, it actually interacts with the iris, causing iritis and pigment dispersion and other issues. So we avoid square edged IOLs. A round edge IOL is better. And the haptics do have a 10-degree posterior angulation. Of course, polypseudophakia comes with its own set of complications such as pigment dispersion, pigment between the IOLs, transillumination defects, uveitis, secondary glaucoma, interlenticular opacification. These are the 4 stages of red rock syndrome, which is in ILO with pigment dispersion. So, and also you can see a hyperopic shift. So, this is an interesting case where a Sulcoflex lens was used. This patient is actually a young 26-year-old female who underwent, who's a high myope who underwent a refractive lensectomy, and she underwent RK for the residual refractive error. She's also undergone a PI. So now what's being done is, since the YAC capsulotomy is a little decentered, initially the posterior capsulorhexis is being extended to make it more central using an Utrata forceps. This is the Sulcoflex IOL. A toric version of this IOL is being used, and actually in this patient it was decided to perform a micromonovision. So for the left eye is dominant, this is the left eye, so it's being corrected fully for distance, and the right eye was kept a little myopic. So this is the implantation of the Sulcoflex lens in the sulcus, and it's rotated according to its axis. So peripheral iridotomy is also being done, which is useful in such cases. So post-operative OCT shows us both the lenses, one in the sulcus just below the iris and one in the back. And post-operatively, she was binocularly 6'6". Her left eye was dominant, so for distance she was 6/6, and the right eye for near she was N6, and binocularly she was 6/6 and N6. So coming to IOL exchange, you can either calculate the IOL power required in a pseudophakic mode or use other software-based formula like the Hilvergence or the Barrett RX formulae. This is a patient who was a young software engineer, and actually a Technis multifocal lens was implanted in this patient, and he was unhappy with the intermediate vision. So this lens is actually explanted, and we have planned to implant a Panoptix multifocal IOL. So this set of instruments is the MST forceps and also the lens cutter. So a trapezoid incision is made so that the internal lip is enlarged, and it's cut 3/4 of the way, and the right half of the lens is pulled out and rotated through the main incision in a very gentle way. So the Panoptix multifocal lens is implanted here. And the LRIs are opened up. This is another case of IOL exchange. This is a patient who was a high myope, and a toric IOL was implanted in this patient, and the IOL rotation kept happening. So the IOL was actually rotated couple of times before he was taken up for IOL exchange. So it's very important to inject viscoelastic under the IOL and lift up the plate haptic. So in large myope, in high myopes with large bags, plate haptics actually cause more rotation than open loop haptics. Here again the same set of instruments are being used, the MST forceps and lens cutter. For plate haptic IOLs, it may be easier to cut the lens completely in half before explanting it, but here it's also done by this method of cutting the lens 3/4 of the way and pulling it out through the right side of the lens. The bag is distended and the IOL is implanted. So this is another case of IOL exchange. So this patient actually came back 2 years post-operatively with a lot of photic phenomenon, glare, halos, etc. So here we see that a fine iris repositor is being used to remove all the adhesions between the IOL and the bag, and viscoelastic is injected under the IOL and it's tried to explant. But we see that the adhesions between the IOL and the bag are quite adamant, and it's very important to use a fine iris repositor as a second instrument to keep the bag in place while rotating the IOL out. Here again it's cut into half because it's a more complex case. Cutting it into half is a more easier technique. While trying to explant one half, you can see that there is a small ZD that happens, which is why again the fine iris repositor is a very important instrument to use. This is a Nightingale polisher to polish the cells on the PC. The PC is thoroughly polished, but we still have that small ZD which is there. So a CTR is inserted into the bag before implanting the. This is a bimanual technique of CTR implantation. So a monofocal lens is used because the patient had a lot of photic phenomenon and couldn't tolerate the multifocal IOL. You can see that the lens is well centered. So in the last case scenario, I would actually like to discuss a very interesting case of optic capture that was done. This was actually a 54-year-old female ophthalmologist who came for a refractive correction for an opinion. She had a high spherical myopic error. And on ocular examination, the rest was normal, but she did have borderline topography, both eyes. So she was unsuitable for corneal refractive surgery, and her anterior chamber depth was, it was quite shallow. So it was 2.32 and 2.27. So she was unsuitable for an ICL as well. So the surgical plan in this patient was both eyes femtolaser assisted refractive lens exchange with implantation of a trifocal IOL with arcuate incisions, and the calculated IOL power was plus 15.5 in the right eye and 11 in the left eye. So 3 weeks post-operatively, she came back with blurring for distance vision in the right eye. So it was 612 parts. And she was accepting -1 spherical and -0.5 cylinder. So here we see the OCT showing us the bag. This is not a case of bag distension syndrome. The folds in the bag are clearly seen. So what was done surgically? So the same incisions 3 weeks post-operatively can be opened quite easily. So the same incisions were opened up, and the edges of the capsulotomy were carefully dissected using the blunt instrument to make sure there were no adhesions. There was viscoelastic injected under the lens. So here we see that the IOL is slowly lifted up. This is actually a cystitome. So what's being performed is a posterior capsulorhexis. And a little bit of sodium hyaluronate is actually injected to keep the anterior hyaloid face down. With the forceps, a posterior capsulotomy is slowly performed very carefully, a little smaller than the anterior capsulorhexis. So here what is being performed is an optic capture. So the same multifocal IOL is being captured posteriorly. So a very slow and deliberate posterior capsulotomy is performed to make sure that it doesn't run off. And the IOL is very carefully captured into that posterior capsulotomy. So we see that at the end of the case, the IOL is very stable, well centered. So in this case, the postoperative refraction was as follows. There was no spherical error, and the patient had 6/6 vision. So this is the post-op 6 weeks clinical result. So the take-home message would be prevention of a refractive surprise is key. It's very important to communicate with patient as to what exactly the scenario is. We have to have a very clear algorithm for the management of such cases. And as you could see, the unconventional options can work quite well. So we can think outside the box. Thank you very much for your patient listening.